Rajendra Sahu, who is a very close friend of mine. He's a pain specialist and he has been trained in Toronto. He has done his fellowship over there. And Dr. Pramod Bhilare, whom I work with in Sancheti Hospital, he's a very nice spine surgeon, and we do a lot of work together. So starting with sympathetic blocks, the first one would be the stellate ganglion block. Now, as you can see, the anatomy of this is, it has a very compact structure in the neck.
Sorry, sir, sorry to interrupt. We cannot see the slides, sir.
You have to share the screen.
Share the slides.
Okay. I thought I already shared it with you. Are you able to see it now?
Yes, sir. We are able to see you. You can go ahead.
Okay, fine. Okay, so sorry for that. So coming to the sympathetic blocks, we first discussed with the stellate ganglion block. Now you can see the neck is a very compact structure which has got the aerodigestive and neurovascular structures all in one. And you need to carefully place your needle very close to the very minute structure, the stellate ganglion. If you see a cross section at the level of C6, this is a blown up from this particular cross section. You will see that this is the C6 vertebra, and this is the nerve root which emerges out, and this goes on to form the interscalene trunks between the middle scalene, the anterscalene, and the middle scalene muscle. On the top of the anterscalene will be the phrenic nerve, and this is the longus coeli on the top of the vertebral body and the transverse process, on which is lodged the sympathetic chain. The whole thing is covered with the prevertebral fascia. The carotid sheath is different, which hosts the carotid artery, jugular vein, and the vagus nerve. And sandwiched in the tracheoesophageal groove, it will be the recurrent laryngeal nerve. So there are plenty of nerves apart from the sympathetic chain that we are targeting. And one more important structure, which everybody needs to know, is the vertebral artery, which is lodged in the anterior tubercle in the foramen transverse stem. So that's again very close to the sympathetic chain as well. So the stellate ganglion is formed by the fusion of the inferior cervical ganglion and the first strip, and it lies on the head of the first strip. This is the stellate ganglion, which lies over the longus coeli muscle as well, and is very in close relation to the first strip, the vertebral artery. And it also receives gray ramacommunicans from the C8 and the T1 as well. Now, this in one of the articles in the original anesthesia pain medicine has been mentioned as a reservoir. In case if you deposit the local anesthetic in the longus coeli muscles, it is possible that the local anesthetic can get squeezed into the stellate ganglion and can cause a prolonged blockade as well. Some of the indications are the refractory complex regional pain syndrome, which has got a 2B plus recommendation is for benefits, which has to be closely balanced with the risk and burdens. And the efficacy is more high if the stellate ganglion blocks are given within 12 to 17 weeks rather than giving it more than 27 weeks. So this is what is mentioned again in the literature as well. Some of the other indications are the sympathetic mediated pain, vascular inefficiency, Raynaud's, phantom pain, cancer pain, post-herpetic neuralgias. These are the case reports or case series where these have been mentioned as well. Now, coming to the technique, now the cervical sympathetic chain lies on the pre-vertebral fascia. So ideally, what many of us we do is with the landmark neck technique is to palpate the Chesnak's tubercle, the C6, and then you guide your needle very close to the C6 tubercle. Once you hit that from the anterior approach, by pulling away the carotid arteries, you deposit a local anesthetic by just withdrawing the needle tip for a few millimeters so that it gets deposited close to the sympathetic chain. So this is the landmark technique by which you pull the carotids away and then you palpate the C6 prior to that, and then the needle is inserted right on the C6 tubercle. You hit it, you come back, and then you inject your local anesthetic. Some of us, we tend to go a bit more below at the level of C7 because the needle is directed when corded. The local anesthetic seeps at the level of T1, and it is at the level of T1 that really it matters, where you can have a good sympathetic block as well. Now we can understand there are a lot of structures here which are present, the jugular veins and the carotid artery, the vertebral artery as well, and the brachial plexus. So the amount of local anesthetic which needs to be injected is after every aspiration has to be very small, and that we are going to discuss again. Now, again, it has been mentioned that if you use image-guided stellate ganglion blocks, they have got an increased rather than going with the blind landmark based or even with fluoroscopy. So again, there's a debate whether the fluoroscopy scores over ultrasound or vice versa. One of the better signs is a Horner's sign, which you usually get immediately after you inject a local anesthetic, but an ipsilateral warming of 1.5 to 7.5 degrees of the arm has been a reliable indicator of sympathectomy as well. Now, we get these endpoints. Now, this is a continuous stellate ganglion block that I had administered in this patient. Now, this is the Horner syndrome, what you immediately get when you inject a local anesthetic. So the other problem is that if you continuously infuse your local anesthetic, you can get a continuous sign of Horner syndrome, which regresses only after you stop this infusion. So that could be a minor problem to the patient, but sometimes it can be blown out of proportion. One of the important secondary signs, as I mentioned, was the local temperature might be, it should be more than 2 degrees in the ipsilateral arm along with the Horner syndrome. And this is what we call as the complete sympathetic. So George Figel, one of my close friends whom I work with cadaveric dissections, he's now moved from Austria to Germany. So he has done remarkable cadaveric works with latex injections, and this is the Fogarty's catheter in the carotid artery, and this is the local, this is the latex which he has given, and this is the vertical spread. So it is the vertical spread which always matters. And this was found with 5 ml. And if you give around 10 ml, then it starts going horizontally as well, and it spreads unnecessarily into the mediastinum. So the volume of the local anesthetic to be injected should be not more than 5 ml according to the cadaveric studies, of course, which may not be extrapolated into a clinical scenario, but this is what is the efficacy in the if you consider the cadaveric study. Now, if you don't image and if you go by just by the landmark techniques, the possibility of the needle penetration of the vertebral artery, the carotids, the internal jugular vein, perforation of the trachea and the esophagus are a big problem. So many of us now, we usually go for the fluoroscopy. In the past, when I started practicing in '94, it was just the landmark base, but now then we started doing fluoroscopy in 2000s, and now since we started having ultrasound since 2006, I have been using ultrasound, and even I think Rajendra must be doing a lot under ultrasound as well. One of the problems with landmark technique is this is the needle in the carotid artery, and you could see the once I inject the dye, you could see the demarcation of the carotid internal jugular as well as the needle, which is very close to the sheath. So this can cause trauma to the vessels, which are really not seen even with the fluoroscope. But with ultrasound, you can see almost everything. At the level of C7, you can see the transverse process. Then you can see the longus colli and the anterior the anterior skeleton muscle, the internal jugular vein, the carotid artery, and then you can go either in plane or you can go with the out of plane techniques. Again, they have from the lateral to medial, from medial to lateral, all those approaches which will be discussed later on. So when I use in short axis, I usually go for in plane, and then I insert the needle from the, I keep the probe on the lateral aspect of the neck. And once I start injecting the local anesthetic, I see the spread in the longitudinal axis. So if it doesn't go at the level of around below this level of C7, then I usually give a head up tilt and then inject a few cc's more, so that the T1 is the one which should be soaked with the local anesthetic agent. What is the evidence? If you consider the block success as Horner's syndrome, increased in skin temperature and blood flow, and a complete abolished skin resistance response. So this is the one that we usually do not see, but we definitely see these the three Horners: increased skin temperature and the blood flow. Now, these are some of the prospective studies which have been carried out by these authors. This was the blind stellate ganglion block in 54 patients, and they had success in just 15 of the 54 patients. And they mentioned that you really require image guidance to increase the block efficacy. Apart from that, there could be a probable failure to block the fiber of Kunz that arise from the T2, and then it passes through T1 and into the upper limb. These authors, by fluoroscopy in 25 patients, they again mentioned that the improvement in CRPS, if the patient comes within 12 weeks, then it's possible to have a good improvement, and there's no improvement at all if it's more than 27 weeks. These authors from Japan, they used ultrasound in 11 patients, and again, the success was 100%. And they mentioned about a subfacial technique with the complication was less hoarseness of voice. Now, Anuj Bhatia, again, he has got a good article which has, they have done a systematic analysis as well as meta-analysis, and they use ultrasound in 100 patients, but they do not mention the block efficacy and the outcome, but they just mentioned that the lateral approach is better than the anterior approach. So coming to complications is basically related to the needle penetration of some of the vascular structures and injection of local anesthetic, or it may block the recurrent laryngeal nerve and phrenic nerve, leading to hoarseness and diaphragmatic paralysis. Again, if the volume is less than 10, the incidence will be less than 10%, and it will increase with more volume of local anesthetic agent. Hematoma formation is basically again because of the penetration of these arteries and vessels, and this was found in 11 patients in one series. So Naroje mentions that, and he argues that only ultrasound can truly prevent complications with direct visualization, whereas fluoroscopy can detect only complications. So some of the unusual indications that I have come across, but I have not used basically myself, is the post-traumatic stress disorders in 653 military personnel at 2 centers in the US, in San Diego and in California. They have got a success rate of 70%, but there were no randomized controlled trials. While in one series of 19 patients they used for ventricular arrhythmias, where the patients were on inotropes and mechanical ventilation, they gave bilateral blocks, and they found 100% success. But again, of course, I'm not sure whether you can really go in for randomized controlled trials in this particular group of patients. Coming to a continuous catheter technique. Now, this is one picture I could obtain from the literature. This is in 1949, where you can see a plastic tube which has been inserted from the posterior to anterior. And this is kept in the vicinity of the stellate ganglion, and then a continuous infusion or maybe intermittent injections must have been performed in this particular case. So I use a simple 18-gauge needle, and then I place the catheter in place, and then I attach this to the infusion pump, which delivers 0.1% ropivacaine at around 2 ml per hour, and send the patient home. But the problem is in 2 patients, one patient complained of continuous hoarseness of voice until the infusion was stopped, and the second patient had a continuous dysphagia until the infusion was stopped. So these are the possible problems with the continuous infusions, and I no longer use these infusions. I just inject the local anesthetic unless the patient has got a vascular insufficiency where you need to keep the catheter in place. Coming to lumbar sympathetic block, the sympathetic ganglion is that it is at the in the close proximity of the intervertebral discs, and it's on the anterolateral aspect on the medial at the medial margin of the psoas major muscle. It receives grammaticommunicants from both the sides, and it is always posterior to these vessels. And it is now likely understood that the needle has to be in the very close vicinity in this particular area. Apart from that, this is the origin of the psoas major muscles from the vertebral body as well as the transverse process. So it is right in front of the psoas major, behind the and it lies behind the anterior longitudinal ligament, but probably in close vicinity of the nerve roots. So there could be transgression of the needle tip through these nerves, which might cause severe pain during these blocks. So you need to be careful when you start inserting your needles. And you can, as you can see, that this is the anterolateral surface. The needle has to be flush with the anterior border of the vertebral body in the lateral view, and in the anterior posterior view, the needle has to be just medial to the lateral border. So if you consider this as the lateral border, the needle has to be just inside the lateral border. So that's the placement of the needle tip when you use this for this particular block. And of course, you need to use a fluoroscopy in this particular. Has mentioned about the placement of the at the level of the intervertebral discs. So probably when you do your blocks, the needle placement has to be as close as to the intervertebral discs rather than the vertebral bodies. So this is one thing that you get you get from this particular article as well. And if the needle is too lateral, then it goes right into the psoas major, and it probably blocks more of the genitofemoral nerve. And if you're using alcohol or phenol, then probably it can lead to neuralgia as well, and to neuralgia in relation to certain lumbar nerve roots as well. So the technique is you make the patient prone, and then you insert the needle around 4 to 5 centimeters. You need to go right across the body, skirt the vertebral body, and then reach the lumbar sympathetic ganglion. Now, this is a basic technique that I used to use in the past, and now you use certain kind of imaging techniques where you rotate the image and then try to move the transverse process out of your view, and then get the anterolateral part of the vertebral body in view, and then insert the needle and on directly onto the anterolateral area of the vertebral body as well. So this is how you do it in the prone position. This is the lateral view, and this is the anteroposterior view where you insert your needle. Actually, the ganglion are still further at this point here, and then these ganglion are actually at this point, somewhere at this point they would be placed. So the medial border of the psoas muscle is considered to be one of the most important anatomical landmarks for a proper needle placement, as mentioned by these authors. So this is the lateral border of the psoas, this is the anterior border, and this is the medial border. And the needle placement has to be at this in this particular area, just behind the inferior vena cava on this side, and the aorta on the other side. And the needle placement is just by the side of the lateral aspect of the vertebral body. So we know the important points. The needle placement has to be at the disc level, and the lumbar is right by the connective tissue of the psoas fascia. So there can be slight trickle of the local anesthetic into the psoas fascia as well. And the spread of local anesthetic, as I mentioned, strict vertical ventral margin of the vertebral body. And in the CT scan, it has to be medial margin of the psoas muscle. So this is the needle which I place under the CT scan. The needle has to be still more further here at this point, and then you can inject your local anesthetic along with the steroids. Some of the indications are the peripheral arterial occlusion, these ones, and the Raynaud's disease, polyneuropathy, burning pit syndrome. This patient had a burning pit syndrome in whom I gave a bilateral continuous sympathetic block as well. This is the patient whom was electron. So this patient had a good relief of 70% pain relief after a continuous sympathetic block where the catheters were placed and the infusions were initiated, and 5 days after which the catheters were removed. This was a pediatric patient where you could see that this probably, after placement of this, the patient started having severe burning pain as well as and foot pain. And I thought probably it's related, it's a sympathetic mediated. So under general anesthesia in the prone position, the radiofrequency diagnostic block initially. In the second setting, the radiofrequency listening was done. And you could see this is the contrast which I mentioned. The needles which are placed in the lateral view, just at the anterior margin, you can see the linear placement of the contrast. And again, you can see a linear placement of the contrast by the side of the just medial to the lateral border. So this is the placement of the contrast when you do a lumbar sympathetic block. With the ultrasound guidance, I usually use it for catheter placements, and this is the 18-gauge needle, and in the prone position, and this is the catheter and the contrast which goes at this point. So it also blocks the gray rami communicans. There is no dye which is going inside the neuraxial space. There is a dye which occupies in front of the psoas major muscle. This is the psoas major muscle. And this is at the level of L1 and L2. It's a bit higher up. Probably at the point of L3 would be more appropriate. If the patient has got foot problems, then I usually go still lower down at the level of L4 and L5. So some of the complications which have been mentioned in the literature is damage to the nerve roots and the genitofemoral neuralgia, as I mentioned earlier, basically because of injection of alcohol or phenol. So what is the evidence? Again, the criteria remains the same: improved rest pain, increased skin temperatures, and healing of the ulcers. So these are all. This is a retrospective study of almost 500 cases under fluoroscopy, and they had a success rate of 72%. This is again a randomized controlled trial in 37 patients, and they mention improvement in rest pain at 1 and 6 months. And these authors with fluoroscopy in 17 patients, they had a success surprisingly more with phenol rather than with radiofrequency ablation. So this is one thing which is going in my mind, why there would be a less success with RFA. Probably Dr. Sahu can answer this. With ultrasound in 42 patients, they had a success rate of 100%, but I do not find any other prospective study. I don't know whether you have come across any other prospective study beyond this, or you have done it yourself. But I usually do it with more with fluoroscopy, and I use ultrasound as a second arm. What in the literature was the use of botulinum toxin in lumbar sympathetic block to improve. This is just a single case, of course, and they found that there is definitely change in the color of the limb as well as in the temperatures what they have measured. So this was something which was new to me, because I have not used this botulinum toxin for complex regional pain syndrome with lumbar sympathetic or even with the stellate ganglion blocks. Now, coming to the last part is the transforaminal epidural steroids. I think also Dr. Pramod would add more to this, being a spine surgeon. Now, these are some of the bony structures which we really come across. That's the intervertebral foramen. And a 20% reduction in height of this will lead to a neural compromise. Again, this is the intervertebral foramen. The number 4 is the intervertebral foramen. This is the psoas major. So these roots, they come out at the level of lumbar, and then they go into to form the lumbar plexus. And this is the erector spinae muscle. So we always describe what is the safe triangle. Now the safe triangle is the one which is bounded by the transverse process, and the upper part of this is the nerve root. And most of us, we usually place our needle very close to this at the 6 o'clock position under fluoroscope. We usually rotate it so that the process goes in, and then we try to insert the needle at this point, where we call it as a safe triangle. And sometimes the needle might hit the nerve root sleeve, and then the spread could be very nicely seen across the sleeve. But if you go still more on the inside of the sleeve, then you might damage the nerve by causing an intraneural injection as well. Now there is one more triangle which is mentioned as the Cummins triangle, and I think the endoscopic surgeons, they use it more. I'm not sure whether Dr. Rajendra, he does endoscopic techniques. So this is what they mention, and I use this sometimes for needle placements, but I find it more difficult. So I go usually for this particular approach, which is I've been using for last 20 years. Now the angle of insertion is said to be around 30 to 65 degrees, and less than 35 degrees will lead to nerve injuries. So it has to be somewhere at this point that the needle insertion for the transforaminal blocks. When you do this, the needle in the lateral view, you can see that it's right in the foramen, and there are almost how many, I would say more than 5 to 6 ligaments here, and you could feel those penetration of the ligaments is a loss of resistance. And once you are there, then you can inject your contrast, and you can see the contrast which spreads right into the epidural space, the anterior and the posterior, and across the nerve roots and the sleeves, and then it spreads in the extraforaminal. So it has to be an intraforaminal as well as the extraforaminal spread. Now, this again, when you insert the needle in the anterior posterior view, you can see that that would be the transverse process which is there earlier, and then when you rotate the image, it goes in, and then you insert your needle just below this at the 6 o'clock position. It should have been still more at this point. And then you once you inject your contrast, the contrast goes right across into the neuraxial space, into the anterior epidural space, and then it spreads extraforaminal. So once you do that, I give just 2 to 3 ml of 0.125% of bupivacaine along with 10 milligrams of triamcinolone acetate. And depending upon the disc protrusions, I usually go for a single level or maybe a double level. And if it's an L5S1, I usually go for a caudal epidural because I find it more suitable for those particular lesions. So this is again the fluoroscopy guided transforaminal epidural steroid, where you can see this is the anterior epidural spread, and this is the lateral in the foramen, and this is the extraforaminal spread. And you can also see the needle right across into the foramen as well in the safe triangle. But it's very close to the sleeve, because you can see the nerve root sleeve, which is also degranulated. So probably this may not cause harm, but definitely if it would have been a bit more on the inside, then this would have been intraneural injection, which should be avoided at all costs. CT guided, I usually don't do it, but just for the sake of academic purpose, I thought that we place the needle along this angle into the foramen, and then you inject the contrast which goes into the anterior epidural space in the foramen as well as in the extraforaminal, and then you give your local anesthetic as well as the steroids. So these are some of the approaches that I've found in the literature, like the transforaminal, the epidural, the transfacet. Now they have used a pre-curved needle. This is one which was very new to me, and I had used this actually in celiac plexus blocks, where I made the needle curved, but I don't know whether you can get those needles in the. To get those needles bent myself and then go right into the celiac plexus blocks. So the transforaminal block, this is a very important article which I have not read in details, but it's very important in the sense that it mentions how the transforaminal approach can be made safe, how the needles can be positioned under image guidance, why do you need a radio opaque contrast to understand the perfect placement of the needle as well as the spread of the contrast, which will is in direct proportional to the efficacy of the block, and how the transfacet approach has got a promising alternative. I have not read the complete article, but this is one which is again new to me. Now coming to the use of steroids. So which one to use, the particulate or non-particulates? Now in the past we used to use a lot of methylene prednisolone. Then we started using triamcinolone, and now we have moved on to dexamethasone because it does not have got aggregates. But if you consider the phenomenon of emboli, then the MPS has more than the triamcinolone and more than betamethasone. So probably the dexamethasone is more safe than any other agent. And whether the steroid carriers are neurotoxic, the polyethylene glycol which is used, now it is less than 2 to 10 times than the normal. So it's less likely to be a neurotoxic agent as well. So probably dexamethasone is the one that you would be using in future. But for now, particularly I use triamcinolone in my case. So the panelists are going to add a lot on whatever has been spoken here. Coming to the last slide, this is again by Anuj Bhatia, and he has done a systematic review and meta-analysis. This is a very good article, and I think each one of us should be in this article. They mention with the forest plot graph, they mention that everything it favors the steroids. All these authors who have been using this particular technique. They mention that it definitely favors steroids. And if you consider the operative intervention, again it favors the steroids. So they always recommend that if there is a pain relief for almost 3 months with the transforaminal epidural steroid, it is not to reduce the disability, and it does not definitely reduce the incidence of surgery. And the dose what they mention is around 40 milligrams of equivalent methylprednisolone. So they do not mention the amount of triamcinolone or dexamethasone, but the equivalent of methylprednisolone which can be used in all these cases. So this is all what I have from my side. The panelists can then add to this. They can ask questions, and then we can discuss everything amongst ourselves. So thank you very much.
Hello, Dr. Diwan. Excellent talk on both the components of the pain block. One, the sympathetic pain block, and the second one, the transforaminal. Me being the spine surgeon, I'm more interested into the transforaminal pathway here. So I just had few things in my mind. Like you said, you are using lignocaine or bupivacaine, or you are sticking to bupivacaine more?
You know, I use bupivacaine along with triamcinolone, and they are all.
Okay. Any specific reason why you use bupivacaine and not lignocaine? Well, most of the.
Yeah, I agree with you because I have seen you using lignocaine, and I have also seen surgeons using lignocaine. It is just because bupivacaine is long acting, and that's the only reason I use, and I use it with contrast, so I know where exactly it spreads. So that's why I use bupivacaine. Rajendra, you can add.
Sure. That was a wonderful talk, sir. So coming to this part, actually, this is what I do. I use always lidocaine, and that also the preservative-free, that is the Gylocard.
Yeah.
Well, the major effect that comes from these procedures is the steroid. It is not the local anesthetic that gives a long-lasting relief. The reason for using lidocaine is that Gylocard specifically is that, unlike Canada, here in India, we do not do digital subtraction angiography. Actually speaking, if we have to be very sure about the spread of the dye, the best technique is to do a DSA in that fluoroscopy itself, digital subtraction angiography, to rule out any remote intra-arterial spread. because there are case reports in the literature where paraplegia has been reported following a transforaminal, lumbar transforaminal epidural injection. Of course, there are plenty of them in the cervical region, which was done in like 10-15 years ago. So now for a transforaminal injection, fluoroscopy guided in the cervical region is a negative evidence because of the complications. A lot of patients died because of the emboli, although so many blood vessels around the foraminal area. So DSA, we are not using those who do in the cardiac, in the cath lab where DSS can be used. That is again further better. If you use anything, suppose even if it comes negative, you don't see any blood vessel, it still can possibly inside some of those blood vessels. If you are using with a lidocaine couple of mLs, you are again safe. Gylocard, you're safe. One thing. Second, there are studies, pretty much most of them from Manchikanti et al. They have conducted only lidocaine plus lidocaine steroid also combined. So they have found only lidocaine also helping. So there is a potential benefit with lidocaine among all the steroids in kind of membrane stabilization, changes in that neuronal activity. So I go for lidocaine. So that is my personally, and I have seen, especially in North America, most of them use lidocaine only.
The percentage would be 2% or the 1% lidocaine?
Well, I always do 1% actually. I just dilute, most of my skin infiltrations, everything is 1% or maybe 1.5% for anesthesia blocks, like some blocks, but 1% skin. I just use 2 or 3 ml of maximum transforaminal epidurals and steroids. Coming to Sir's point of steroids, like all those listeners, what I can add, the complications are because of the deposteroids. Any kind of patient coming walking because of the pain, and just imagine because of the inability to identify which is the intraneural, subdural, or kind of intrathecal dye spread. It's not a perfect perineural or the epidural dye spread. If one is not able to identify that, and ends up with the patient ends up with some complication, neurological complication like a paraplegia happening, that can be devastating. So for that reason, the safest thing is to use dexamethasone. Actually, studies, there are comparative studies, dexamethasone with triamcinolone or deposteroids, not a significant amount of difference in terms of duration of the pain relief. Okay, so another thing that I want to highlight, that if you're doing a transforaminal epidural, that to specifically L2 or above, suppose you're doing L2, L1 or those levels, definitely no deposteroid. The reason is that the artery of Adam Q is that the biggest artery, 70 to 80%, 82% on the left side, around from T4-5 to L2 in that region that enters the spinal canal. There is a possibility of that small blood vessel or the feeding blood vessels getting breached and leading to anterior spinal artery syndrome. Suppose if you're doing at the left side, L2 or above, better be with only dexamethasone. Good thing in Canada, we had preservative-free dexamethasone. Unfortunately, it is not, I have never seen a preservative-free. But that being said, whatever dexamethasone that is available with us, they're equally efficacious. I have been using dexamethasone with lidocaine for last 4 or 5 years with good results actually. On the right side, lower lumbar, which is the commonest, like L4, L5, or even S1 nerve root, the traversing S1 from a L4, L5, S1 disc bulge. So methylprednisolone is pretty safe, but I make sure that always. Another thing I will add, once I have injected the dye and make sure that dye spread is very good, perineural epidural spread. Then before injecting the steroid, I use lidocaine, first local anesthetic. Suppose if you are using bupivacaine, no issues. I just use lidocaine or local anesthetic to make sure that how the dye is getting washed off. If there is a getting good dye wash off, that means it is in a perfect position. There is no blood vessel, it's not in any blood vessel. So then subsequently I inject the steroid. So that is one thing that I wanted to add.
Right. So I completely agree with Dr. Rajendra that even I prefer using lidocaine over bupivacaine. And the reasons what you have quoted has been my reasons also. Only glitch I have found out was in case of daycare patients, because most of our lumbar pain blocks are daycare pain blocks, and they usually have to rush back to their houses within 1 or 2 hours of their block. And especially the lidocaine, with the lidocaine and a transforaminal route, if the volume of drug given is more than 4 ml, we have found out that transient weakness is a very common problem with them. And though it is transient, it kinds of gets kind of early negative feedback from the patients and their relatives that they are having weakness, we usually counsel them that yes, even if there is a weakness, it usually settles down in a coming 1 hour or so, and then after 3-4 hours they can probably go back. So only in those cases I usually prefer bupivacaine, but otherwise most of the cases I usually prefer lidocaine, and that to 1%, because more than 1%, I've seen a couple of times that if you use 2% high concentration, high volume lidocaine, then it does cause motor blockade and kind of again gives not a very good feedback from the patients and their relatives. So that's a issue considering. And the questions regarding the steroids, I agree that being a particulate steroid, it can block artery of adenoids, and theoretically it can lead to paraplegia. But very rarely I've in my practice I've still yet to see that. But I know a couple of cases, not done by me. It can happen with anyone. But a transforaminal block at as low as 4-5 and 5S1 also has led to paraplegia. And on subsequent evaluation, it was found that the artery of Adamquiz, as you rightly said, starts somewhere at the thoracolumbar junction. It was starting as low as alpha S1 junction. So you have to be very, very particular. Those are very anecdotal cases. You cannot generalize to everyone. But then you should be very particular to use a dye, confirm it that you are not intra-arterial. If you have options or provision of DSA, do it for all your cases, and probably you will, 1 in 1 lakh probably such case will come, but you never know what kind of cases you are doing, especially if you are doing in a high volume cases.
Do you mean to say that 1% lignocaine, just around maybe 2 to 3 ml, will cause cordyceps weakness, or maybe maybe a foot drop?
Actually, both. So what even the recommendations are, the volume should not be more than 4 ml, or the percentage should not be more than 1%. So if you are using 2% lidocaine with more than 4 ml through a transforaminal route, then you can see this transient weakness. And most of the time it is transient. You need to assure the patient, or pre pre-injection you just prime the patient that you might face this problem, and usually settles down in a couple of hours.
Last 25 years, I've been giving transforaminal 0.25% or 0.125% bupivacaine, around 4 ml. I have not come across any cordyceps weakness.
Actually, that's the problem. I have not seen anything with bupivacaine. So the reason recently I had one case where I had given transforaminal approximately 6 ml diluted to 6 ml saline as well as the steroid, and the patient had a transient weakness. And in fact, we had a good discussion with other spine surgeons, and most of were of the opinion that usually this weakness is seen with lidocaine and never with bupivacaine. So I just, for the same reason.
Well, possibly it could be some intraneural, maybe, maybe some of this medication possibly was very close to, just below the epineurium, could be.
So apart from that, even lignocaine has got a more motor effect than
bupivacaine.
So that could be a possibility also.
Yes.
One thing I used to do in the past when lignocaine 5% was available for spinal anesthetic, I used to inject at the level of stellate ganglion block for a stellate ganglion block in cancer patients.
Sure.
Instead of using phenol or alcohol. Did you use that anytime? Because
since I joined pretty much late, 2006 I joined in Mumbai, so I never used that. So I was about to come to that stellate ganglion. Can I? So is your approach is always fluoroscopy guided or ultrasound? So what message you want to give to our viewers? What is the best imaging modality for a stellate ganglion block? According to you?
Rajendra, see, I have been exposed to this landmark technique and fluoroscopy technique for last so many years. It is only from maybe 2006 that I just started scanning for the stellate. So I'm not very comfortable giving only with the ultrasound. though I see all the structures. I am more comfortable with giving with the fluoroscope, but now I of course double check it with ultrasound since we have the facility to do that. So the spread of the local anesthetic, I always double check it.
Okay. Well, I have few points to make here actually for all those viewers. This is actually important for all those either from the pain specialist, for maybe anesthesiologist who occasionally practice pain. And as you rightly made one slide also, there are other indications, non-pain indications like PTSD. Yes, what you showed, it was not a randomized trial. In one of the randomized trial published in 2017, and they didn't find a significant effect, but of course it has been used very with a lot of patients in post-traumatic stress disorder as well as ventricular arrhythmia, electrical stum, refractory ventricular arrhythmia, patient getting all kind of medications, then they have IICD in place, multiple circ that is not helping, and stellate ganglion block has been found to be effective. We recently published one paper in Annals of Cardiac Anesthesia as well, case series. So they do help. So those who are not doing, they should learn this technique. It is just an extension of the interscalene block they do. So few things I want to mention here. You mentioned about the landmark guided. You feel for the C6 antitubercle, go hit the transverse process, withdraw a little bit, inject there, high volume, those times 10, 15, 20 ml, and then fluoroscopy also. But every procedure, interventional procedure that we do for anesthesia, pain, or kind of prognostic, diagnostic block, we have to see how safe that procedure is, which imaging guidance is most safe for the safety, efficacy, outcome. In all aspects, ultrasound outweighs the fluoroscopy. Definitely, definitely landmark. There is no doubt on that. The reason, so we have esophagus there. There are reports of needle puncturing, especially on the left side, in that landmark guided, or even if fluoroscopy, needle going there and touching or kind of damaging the esophagus in patients with the diverticulum leading to mediastinitis. Also, we have blood vessels, as we saw in one of those slides. At C7 level, in C6 also, C7 vertebral there, in C6 also, in around 7 to 10% of the individuals, vertebral can be extraforaminal blood vessels. Oftentimes one see in 25% of patients, inferior. So that is again at risk. Many other small aberrant blood vessels, nerve root, all those kind of things are there. So everything can be very clearly seen with ultrasound. You can avoid C5, C6 nerve root. You can avoid vagus. You can avoid blood vessels. You can avoid this esophagus. Everything can be avoided with ultrasound. Then the location, where exactly the stellate ganglion is located, though it is at C7T1 level, the stellate ganglion has been found to be lying on the surface of the longus coli. One of the slides we saw surface of the longus coli, which is covered by the prevertebral fascia. In one of those Japanese papers, Shibata et al. You saw, so they suggested that was pretty earlier, it was a subfascial. That means the injection has to be, the local anesthetic deposition has to be just below the prevertebral fascia on the surface of the longus coli muscle. Okay, and there are studies comparing the ideal volume. There is a Korean study, they compared 2 ml, 4 ml, and 6 ml, and they did on 4 different sittings. So what they found, 4 ml to be the optimal volume. There are other studies, you quoted that also. 4 to 5 ml of local anesthetic done at C6 level, chasagnas tubercle, and lateral approach, from the Bhatia paper also, lateral to medial, just on the surface of the longus coli. As you go, you pierce the longus capitis muscle, just pierce the prevertebral fascia on the surface of the longus coli muscle. If 4 to 5 ml of drug is deposited, the sprayed subsequent cadaveric study they found from C4 as low as T2, C4 to T2 with 4 ml of sprayed. So that means with ultrasound, you can reduce the volume. Earlier it used to be 10 ml, 12 or 15 ml. You reduce the volume. You deposited safely at the C6 level from a lateral approach. You avoided all those blood vessels. If you do at C7, you can still do what? It's not like that you cannot do what, but make sure that you do not see all those aberrant blood vessels, esophagus, all those things. So those are few things I wanted to add when it comes to a safely performing the stellate ganglion block ultrasound lateral to medial approach. That is recommended actually. You can do an anterior approach out of plane from medial to lateral out of plane, but the best is lateral to medial on the surface of the longus colli below the prevertebral fascia. Best is at C6. You can still do at C7. Make sure that there is no aberrant blood vessel. And volume, if you're just doing it, we have seen it, by the end you just finish the block and just patient is shifted to the recovery in 4-5 minutes time. Classic ptosis, ptosis, meiosis, all those classic symptoms of the classic findings of the Horner syndrome, you see it. So that is one thing that I wanted to add. Stellate ganglion block, sir. Anything, sir, you want to add? Hello.
Yeah.
Sandeep, sir.
Yeah, coming back to the foraminal block. Thank you, Rajendra, for those inputs of the stellate ganglion. Both of you, can you comment on the L5 S1 disc protrusion and radiculopathy? What would you choose, L5 S1 foraminal or a caudal epidural?
S1 selective nerve root block. So in a L5S1 prolapse intervertebral disc, where it is a paracentral disc extrusion most of the time, it is a S1 nerve root which is at fault and which is compressed and inflamed. So in that case, we like to give a S1 selective nerve root block to an S1 foramen. But caudal epidural, in my textbooks, it is mainly for diffuse kind of involvement involving multiple sacral nerve roots. I usually prefer a caudal one. I usually don't like to put on caudal more in my practice. I use transforaminal more than would be caudal, and very rarely I would use an interlaminar technique.
Okay. So for these things, like if the patient is having, as you told rightly, most of them, they do have S1 also, and sometimes patient not unlikely to have L5 as well. So the approach can be two. I do both. We do S1 also, L5 transforaminal and caudal epidural. As you told, sir, for us, I use caudal epidural a lot. The reason is that what I do, if you are just using a spinal needle with fluoroscopy guided, if you do the injection, so then possibly most of the drug might spread to those sacral nerve roots, S2, 3, 4, or S1 like that. So what I do, I use ultrasound, I put the needle pretty much parallel, okay, and then I use the catheter. I put the catheter. So with that technique, initial dye will be kind of delineating the S2, 3 nerve roots. But with catheter and with ultrasound guided parallel needle placement, I direct the catheter to L5, S1, those areas. So selectively, at the end of the technique, at end of the procedure, all my medication, they just wash off the L5, S1 area. All those previously S2, 3 with the initial dye spread through a needle without the catheter, they remain intact. But basically with the catheter, I just go that area. Caudal epidural, excellent. I think there are studies comparing caudal epidural transforaminal, equally efficacious, good result also. With transforaminal, couple of times I have experienced like, bit of intraneural injections, subdural placement of the dye, the patient had kind of nagging pain for a long time from those procedures. For a while, I stopped doing transforaminal, especially L5 S1s or 2 or 3 levels. I did exclusive caudal epidural with very good results actually. And for L5 S1, sir, what I do, I go Campbell's triangle approach. Instead of the safe triangle, if you go at the Campbell's triangle, so your dye can, of course, and you can, if you tilt the needle tip, of course, we bend the needle tip. If you just redirect the tip inferomedially towards around 7 o'clock position, that also, covers both the traversing S1 route and also spreads around the exiting L5 nerve route. So Campbell's approach where S1 is also involved, that I do. But yes, exclusive occasionally we do that also, S1 nerve root block, exclusive S1. But most of the cases, they do have pain from L5 as well. If just I do selective S1, so, it is not that only the S1 exiting S1. So we have to kind of clinically look for which one is getting more symptomatic. Is it on the lateral side of the foot, describing, or is going to the dorsum, big toes as well, in the both sides. If it is both, then you go for a technique where it covers both L5, S1 as well. Caudal epidural is a good choice in that case.
Yeah, I agree that it entirely depends on your clinical acumen and clinical symptomatology and dermatomal distribution, that which kind of block you want to administer to the patient. But just a thing here that alpha S1 actually to go to an Camden's triangle is kind of headache for us.
Yeah,
Since
yes.
many a
That
time
over and
L5 is a settled one, it is way below the iliac crest and approaching. In fact, even for the endoscopic spine surgeries, we, if at all we are planning a alpha S1 transforaminal discectomy, we might have to put an iliac crest hole, burr hole, and then do the procedure. If yes, but if the L5 is way, it's not receded below the iliac crest, is way above, then usually we can get away with a Camden's triangle approach at L5 as well.
One more thing, in the past, I used to do a lot of, caudal epidural neuroplasty with the catheter in place and then inject normal saline, and at times I used to inject hypertonic saline also. So is that, of course, I stopped it now, long back, but anybody uses it till now, or it's an obsolete thing?
No, sir, people are using, sir. We are using also.
Okay. You use hypertonic saline as well?
Hypertonic, no, it is normal saline. Normal saline, some Hylas, dexamethasone, these steroids, not hypertonic anymore.
But is it basically meant for failback, or you use it for all?
No, that is for all those post-laminectomy pain syndromes, for this carrying epidural fibrosis, all those failed backs, basically for those patients.
Right. So anything else to be sorted out, or I think we have done with everything.
No, sir. Yes, yes. We covered everything. You did a great job, sir. Fantastic, sir.
In fact, your presence has enlightened everybody, both of you, Pramod sir and Rajendra sir. Thank you very much.
Thank you. Thank you. Excellent talk, sir. Very good overview. I've gotten pain specialist point of view into the discussion, so that will help my practice also. Thank you very much for the talks.
Thanks a lot, sir.
Thank you, sir. It was a pleasure listening
for
to you.
Vote of thanks.
Rahul sir.
Pramod sir.
Yes.
May I request you for vote of thanks?
So I think an excellent talk here by Dr. Sandeep Diwan, who are our important cog in the wheel whenever you talk about anesthesiology, academics, and the department itself. He has delivered an excellent talk. Thank you, sir, for an excellent talk. Dr. Rajendra Sahu, it was an excellent presence from your side, your inputs into the discussion. I think it has made me more wiser here as far as my practice is concerned. And it was a great insight to look into the pain specialist point of view whenever you give an epidural steroids or whenever you give a stellate ganglion block. So with this, I would like to conclude the webinar today. And thank you all. Thank you, the panelists. Thank you, speaker, for giving your valuable time.
Thank you. It was a great pleasure, actually. Sandeep sir is one of my teachers. I actually learned ultrasound from him. It was in 2008